number one, it can be a wire which is not for the purpose of wiring. Okay, then you won't achieve your purpose. Second, example would be if it's an auto wire that you're using. Okay, an auto wire would not be suitable for you to tie the teeth. Okay, it will actually loosen up after a while. All right, so the wire that you use must be correct. The diameter of wire also is something important. Okay, having worked in different hospitals, in different roles in ministry, I can tell you we have wires which are various types and sizes. Okay, ideally you should use 0.5 mm. Okay, and in one of the places I worked, they are so particular. We use 0.5 for the posterior and 0.3 for the anterior. Okay, so that consultant was like that particular. So 0.3 or 0.5. But a lot of other places I worked, there was like 0.7, 0.9, okay, 0.6 was all over. Okay, and a lot of places they just stick to one size. Right. So important to know what wire you're using. If you don't have the choice of the diameter, it's okay, as long as you know whether it's the correct wire or not. Because a lot of clinics will also have auto wires. Okay, if you use that, you'll be wasting time because you finish tying, you realize it will spring back. Here it will become loose. So when you get the wire, what's important is pre-stretch them. Okay, pre-stretch them. I think I told some of you just now. Usually you get at least pre-stretch to easily 10-20%. Okay, some up to 30%. So it depends on what wire it is, and each wire has its own stretching capability. Okay, so that one usually we don't bother so much because the technicians will usually procure for us. Okay, in government service, you don't need to buy all these materials. The technicians will buy it for you, and you just need to know whether it's the specification that you want. Okay, and usually the technicians will also pre-stretch for you, or your DSAs will pre-stretch for you, because as a officer you won't have time to do all these things because you will have trauma coming in, like anything. Okay, depends where you are centered also lah. Some places you won't have trauma even for a whole month, okay, or 2 months. Okay, so when you have pre-stretched the wire, okay, what you need to do is usually they would pre-cut already. Okay, the DSA or the technician will have pre-cut for you. What you roughly need to know is you just need a size which is sufficient for you to. Okay, so this is quite a soft wire lah. Okay, ideally it should be a little bit firmer than this. Okay, so the length that you need, because just now some of you were asking what is the length you need, you just roughly need. Okay, so you just roughly need something that you need to hold on to this side with a loop. Okay, can you get it? Okay, that is the length that you need to cut. In fact, this one you can even have it a bit shorter, but if you're not someone very you're a beginner, better to have it a bit long. Okay, because if you have it a bit short, then you might have difficulty to. Okay, some of us who are used to it, we will have it a bit shorter. Okay, and the thing is, if you do it shorter, your margin of error is low. Okay, you cannot have a mistake, because with short wires that you're working, if you don't twist properly, gone. You have to throw away the wire and redo. If it's a longer portion that you're working with, you have the choice of correcting it while you're doing it. Okay, I'll show you how. Okay, so how much to cut, you can roughly estimate around that. Alright, so roughly this is the size that you need for each. Okay, approximately. Alright, so what we tend to do is usually for maxilla or mandible, pretty much the same. Anterior, you will have at least central incisor, one of it. Okay, preferably canines also. Okay, what I'm meaning is you will have to have a wire around it. Okay, for you to tie the ashbar. Okay, use the strong teeth usually. Central, canine. We do take one of the premolars, okay, and molar. Ideally, what I tend to do is I'll take 1, 3, 5, 7. Okay, sometimes doing 7 in the mouth can be quite difficult. Okay, so if you're a beginner, even if you do up to 6, a lot of oral surgeons are quite okay with it. Okay, unless you're working with some consultants who are very strict. Okay, like the person I started off with was quite strict. He wanted no matter what up to 7. Okay, so it became a habit. I continued doing up to 7. But a lot of places later where I was working, in different units, they're more than happy if you can do up to 6. Okay, so use those important teeth. Okay, because they give you stability to the archbar. Okay, central, canine, one of the premolars, and molar. Okay, clear? Alright, so you need at least about 3 to 4 wires of this for each quadrant. Clear? Okay, so approximately you need about 6 to 8 per arch. Clear? Clear. Okay, good. Any other questions so far? Any questions so far? Yep.
Let's say 6 or 7 is missing.
Okay, fine. If it's a missing, then you go for the next adjacent one. Okay, that's a very good question because you may not have all the sets which I mentioned just now. So whichever is missing, go to the next, which is to that anchor wire, meaning like if you don't have a 7, go to 6. If you don't have a 6, you can use 7. Okay, you don't have a 5, you can use 4, something like that. But usually you skip one tooth, you know, when you're tying. So 1, 3, 5, 7. So you're skipping one each. Some people do it at a larger interval. Okay, they go straight like central, premolar, 1 molar like that. Okay. The thing is that if you are very good with your arch bar, with the tying and all that thing, it's okay. But still, I would say it won't give you a very good adaptation, because basically the more wires you have, the better the adaptability of the arch bar to your dental arch. Okay, because these wires actually help to adapt it to it. Okay, alright. So the lesser wires that you use, the lesser anchorage to the arch bar you have. Okay, clear so far? Alright. So once you have these wires, next thing that you need to know is the arch bar. Okay, arch bar usually also comes in a coil. Okay, it comes in, you know, long rounded coils of the arch bar. Okay, you need to cut. Okay, again, a lot of places they would have pre-cut for you. How do they pre-cut? It is estimated. Okay, they roughly estimate the arch size. Okay, and they take an average size and cut. Okay, so what you need to do if you already have a pre-cut arch bar, okay, what you need to do is you have to measure against the arch that you're going to tie. Okay, you have to measure and cut accordingly. Okay, don't have it too long, because what happens is if you have it too long, it's going to be poking your cheek. Okay, the buccal mucosa. Okay, if you have it too short, you won't be able to tie sufficiently. Okay, so it must be just about right. Sometimes what we do is we measure, because we've been working like many years with this damn thing, so we won't measure lah. Before I cut, I straight away like, okay, 2, 4, 5, 6, 7, 8, pop, 18, pop, cut. So you know, it's like usual measure is about 14, 16. Okay, cleats. What I'm saying is the measurement of cleats. Okay, this hook that you're seeing here is known as cleats. C-L-E-A-T-S, cleats. Okay, C-L-E-A-T-S, cleats. Okay, so you measure the cleats. Okay, you should roughly have about, you can safely cut at 16 usually. Okay, 16. If you are just going to take it from the coil, you're going to cut, you at least measure 16 and cut. And then what you do is always put on the person's arch and measure. Okay, invariably if I'm working with a patient, I will always put on their arch and measure. Okay, because if you have it a bit longer and say, never mind, let me have it a bit longer and tie first and then I cut, very difficult. Especially if you already have a very good adaptation to the arch, it is very difficult for you to cut after, because usually your we don't use this like. Can you imagine using this to try to cut? It's very difficult. Okay, and we have a specialized wire cutter. Okay, but it's damn difficult to cut the arch bar usually, because if you don't aim it at the right area and cut, you'll be cutting for the whole morning. Okay, so best is you have it on at the right length, so that you don't need to do all this cutting after. Okay, and by trying to have it adapted and then manipulate to cut, you're going to also cause it to become loosened. Okay, so you don't want it to loosen after you've adapted it well to the arch, right? Okay, any questions so far? Clear? Okay, so these wires I told you roughly have to have about 6 to 8, and then you need to have the arch bar which is appropriate to the arch length. Okay, next thing that you need to do is you need to know whether you're doing the upper arch or lower arch. Okay, this is very important. If you determine to do the lower arch first, okay, then or the upper arch. Ideally, okay, it's your choice, but usually, conventionally, we start with upper arch first. Okay, usually we start with the upper arch first before we go to the lower arch. Okay, but if you want to do it reverse, up to you. Okay, it's as per clinical circumstances as well. Sometimes you have a mandible fracture which is very mobile, and you have maxilla which is firm. Okay, so no maxillary fracture but mandible fractured and mobile. So maybe you would want to stabilize the mandible first. No worries, can. Okay, or you want to do the firm one first before going to the difficult one, also can. Okay, I will still go for the firm one before I go to the fractured segment, because if you manipulate the fractured segment, definitely the patient is going to have pain. Their cooperation after that, before you do the upper arch bar, is going to be more compromised. So do the things which is less painful first before you go to the painful part, because I'll quickly do the painful part and then send them off to the ward. Okay, yeah, and if you do it properly with arch bar, okay, you don't even need to plate the fracture. Okay, alright, that's how well some of us can reduce. Okay, that you got a very nice approximation of a displaced fracture. Okay, you can re-approximate properly and get them into perfect occlusion, and then we tie. Okay, so if you're planning to go ahead for open reduction, when we release the IMF in OT and we make an incision and expose the fracture site, bang, it's already like bone to bone. I just need to like take plates and pop, screw, done. Very quick. That's why some of them think, wow, how come you do fracture so fast? Okay, it's because if your wiring is good, your OT time is very limited, because you've already got most of the job done. But at your level, okay, your aim is very simple. You just need to get it back into position. Even if you don't have a fantastic reduction, don't worry, it's okay. Alright? Because the job of making sure it's well reduced is not really yours. Okay? It's just that I was very kiasu last time. Okay? For personal satisfaction, I have it done like that perfectly well, even at emergency level. Okay? So that's why people used to know, oh, this guy, he did it. Okay lah. In OTB, simple. Because well reduced in ED itself. Okay? But in emergency department, usually don't bother. Your aim in emergency department is mobile fracture, make it immobile, and reduce bleeding. That's it. Because if you're not used to it, you'll be struggling a lot. Okay? I used to have people who are senior to me and also junior to me calling me middle of the night because they cannot release fractures. Okay? Because I used to do specialist call as an officer, so I'll always get called whenever they need rescue. So it's not worth trying to be a hero there unless you're really good. Okay, so I can come and very quickly do, within 10 minutes I'm done. They'll be struggling for 2 hours, they cannot do. So don't try, just do what is necessary, which is reduction so that it's not mobile. Second, not bleeding. Nobody in their sane mind would actually scold you, okay, if you can get these two done, which is actually the primary reason for treatment at the emergency. Okay, stop bleeding and prevent it from being overly mobile. Okay, any questions so far? So when you've decided what to do, very important, remember this forever, as long as you're in oral surgery to do any of this. Always make sure where is the cleat facing. Okay, always make sure, because I can tell you, I'm very sure in this group also, some of you are going to do it. Because I can tell you, over the years, I've seen so many officers under me, okay, my own colleagues, okay, in their overzealous enthusiasm, hey, I got an arch bar to do. Start doing it, like, wow. End of the day, when some of us come and say, hey, how come your arch bar is like upside down? Oh shit, this is not uncommon, this is very common in people who are beginners. 2 hours they'll be doing, only to know, for upper arch, your cleat is actually facing like this. Okay? Which is wrong. It should always be facing opposite direction. Because if your cleat is facing down, your cleat should be facing up. Because you need the cleat facing up to hook your wire to tie. Okay? Because if your arch bar is actually facing with the cleat down, it may help you just to stabilize the fracture pattern. Okay? But you can't put them in IMF. Okay? IMF is an immobilization, Alright? It is actually required. If you're placing an arch bar, it's pretty much understood that it is also for IMF. So you can't just tell me I'm doing arch bar just for the sake of reduction. Because if you're just doing arch bar for the sake of reduction of fracture, it's an overkill. Okay? Because I've got so many other things in my hand that I can do in much quicker time to achieve that objective. Okay? You can do eyelet wiring, okay? A few other types of wiring to actually reduce the fracture segment. Okay? So the purpose of actually placing an arch bar is understood. You're placing upper and lower, and you're going to put them in IMF. So the cleat direction is very, very important. Okay, very important. Okay, any questions so far? So going by sequence, one thing you need to know is length of wire, cut. Okay, pre-stretch the wire. Okay, so I was telling some of you, roughly about at least 10-20% you need to be able to stretch. So if you're cutting it at 10 cm, you should have it at least at the end of the procedure 11 to 12 cm. The length should increase from 10 cm to 12 cm. Okay, that is about 20% of stretching, right? Okay, got it? So pre-stretch, pre-cut the arch bar, at least with 16 cleats to be on the safe side. Okay, 16 cleats, and then once you've got it at a smaller, manageable version, measure again against the arch. Measure again against the arch of the patient and cut further if necessary. Okay, cut further again if necessary. So, yep.
So if we are planning to put loops on 7, so the arch bar should extend up to the distal surface of 7.
Distal of 7. Yep. Okay, up to distal of 7. Alright, because if you cut short, which is common when you're cutting, you may cut short one side, then you cannot extend all the way. Okay, but at least as I said, if you can do up to 6, it is acceptable. Best if you could do until 7. Okay, alright. So you've already pre-cut according to the size of the arch. Next thing, as I mentioned, very important, direction of the cleat. Okay, make sure direction of the cleat is proper, and then only you do the wiring. Okay, so as I said, the anchor teeth is central. So anchor teeth central, left central, canine, premolar, molar. Okay, one premolar, one molar. Right.
So the two centrals will be adjacent to each other. The two centrals.
Yes,
will be adjacent.
you can. But sometimes what we do is, if you do 1-1, then you do 2-2. Because you do 1-1, your 2-1 is beside you, right? Then you do 2-2. Yeah. So you can use your what do you call that? Discretion. Or you want to do both central to central, also no issues. Okay? Yeah. Central, canine, premolar, and first or second molar. Okay? Yeah. Symmetrical. Okay? Clear so far? Okay. So when you're doing the arch bar, you can't do it alone usually. So you need an assistant. So at least one assistant. Usually if you're a beginner, you need more than one assistant. So one person has to hold the arch bar down to the arch. Okay? While the other person actually have the wires in. There are a few ways to do it. What most of us do is, okay, method 1, you predetermine the length of the arch bar. Okay? Once you've predetermined length of arch bar, you cut and then you keep it aside. Alright? And then you place the wires at all the anchor teeth. Okay? Come. Sorry. So I'll just give an example quickly. Okay, this one I'm just using my finger. Okay, by right we are using our, what is this? No? Not artery fossa, we call it Y twister. Okay, it will look very much like a needle holder. Okay, but it's actually not a needle holder because for wiring purpose it's a special tool. It's actually thicker usually. Okay, the beak will be thicker. Some of it will be gold plated. Alright, they are your Y twisters. Okay, so ideally use your Y twisters. If not, also it's okay. So one method is to have your wires in first, and then you slide in your arch bar. Okay. The other method is, as you put the or as you have the arch bar adapted, you put in the wire manually one by one and tie it. Okay, tie it one by one. Invariably, we use this method. Okay, invariably we use this method. All right, because I'll tell you why. What we tend to do is we have the wires inserted, and we would bend one up, one down. Okay, you have one twisted down, one twisted up. Okay, this one every time a lot of people will ask me, doctor, which wire goes down, which one goes up? Okay, if you look at the books, I think they won't tell you. Okay, but by common sense of having worked many years, those of us with skill and experience, we know which one to go up and down. Okay, usually for the we call this as mesial and distal. Okay, the wires mesial and distal. Okay, so if you are in a unit and someone asks you, so distal up or distal down? Okay, alright, that's the common way of telling. If it's me, for the upper, okay, if it's a 7, it's your last one, okay, I would want the what do you call that? Distal wire, up or down? What do you think? Up or down? The distal wire. Because what determines usually whether it goes up and down is actually your distal wire. Distal wire of the distal tooth. Okay, let me try to make you understand. If you're tying this arch bar, which direction do you want to prevent it to sink in? Okay, if it's the upper arch bar, do you want to prevent it sinking upwards or sinking downwards? I'm getting both answers here, up and down. Okay, because I'm telling you why. As you're doing, you'll realize your arch bar will tilt upwards like that. Okay, sink in upwards. That's what I mean. Okay, tilt upwards. Okay, or you can tilt down towards the occlusion. Okay, you can tilt down as well. So which one do you think you want to prevent? Tilting up or down? This one I can tell you a lot of things that I'm telling you, you won't find in books, you won't find in any resources. So yeah. So which one do you think? And this will determine whether your distal wire goes up or down, because then the rest will follow. So which one? So this, okay, so I'm showing now again. So you think now distal up or down? Huh? Logically. Okay, now decide first, you want it to prevent sinking upwards or you want to prevent it sinking downwards?
Downwards. Prevent sinking down.
Huh? Prevent sinking down. Why not upwards?
Because the lower jaw will pull it down.
Okay, in IMF. Okay, so you think it'll come down. So with IMF it's going to come down, right? Okay, so you're preventing it from coming downwards. But have you thought that if you don't, it will also go and injure your soft tissue up there, which is very painful, you know? And usually that's what makes the patient not tolerate the arch bar. Okay, all this nitty-gritty thing is what will make two people who do arch bar, one patient or the same patient, person A does, the same person B does. Person A, they cannot tolerate even a day. Person B, they can have it on for 3-4 weeks, which is typical when you have an arch bar on. Okay, so all these nitty-gritty things. Okay, so basically I would want, if it's the upper, I would want the distal wire to be down. Okay, I want the distal wire to be down. Alright, wait, let me think. I haven't done since 2017 actually. Yeah, sorry. If it's up, I want the distal wire to be up. Okay, I want the distal wire to be up because I don't want this to sink in. Okay, so I'm having my distal wire to actually help bring it down, control it downwards. You understand? Your distal wire, when it's there, it's preventing the end tip sinking in. Okay, this is one thing which I think no books will tell you. I don't know what other resources you need, they won't. Okay, so once you have your distal wire up, okay, then your mesial wire automatically comes down. Everything else will follow the same. Okay, so first thing we communicate is distal up, distal down. Okay, distal down. Okay, so all of us will follow the same. So you will do on one side, because usually we stand left and right. Okay, so each of you, when you're standing left and right, you would do your wires up and down like this. Okay, it doesn't, because the contact point is loose. Huh? So that's the other thing that you'll be facing when you have a teeth with loose contact. Then you will have to do it last, because if not, the wire will keep being displaced. Okay, if you get this fundamental concept right, then your technique wise is not a big deal, I can tell you. Okay, if your fundamental is lousy, then it's totally gone. So you got it, all my distal wires are up. Okay, all my distal wires are up, and all my mesial wires are down. Got it? Okay, and then what you do is you just slide this damn thing in like that. Okay, just like that. All right, so once you slide it all like that, because you've already created the groove for it to slide in, all the distal one up, all the mesial one down, put it right through, and then immediately, while one person is holding the arch bar down to the arch, okay, to the teeth, one of us will tie. Okay, and we'll tie. So up to the midline, one person do on one side, then the other person will do from the other side. Okay, this one about tying, there's also some trick. What a lot of people will do is they will tie, they want to do fast. Okay, every one of you want to shortcut and do fast, right? Yeah, that's why if you are a shortcut person, orthosurgery is not for you, because you will do shit job. Okay, so you have to do it in one direction, because I can tell you, say, hey, you tie from that side, I tie from this side, because you've got the arch bar in already, you want to save time. Can you imagine what will happen? Can someone guess what will happen when you tie from both ends?
Extra material at the center.
Exactly. It will bulge up at the center. Okay? You cannot rectify that. Okay? You cannot rectify that. So, two ways of tie from one end, make it adapt as tightly as possible as you go on, and iron it out to one end. Okay? Every time you are adapting it, keep adapting every wire. I'm telling you, I do this for, like, you know, up to 2017 regularly. Okay? If you ask me how many arch bars I've done, I can't remember. Okay? Could it be thousands? Maybe. Okay? I can tell you, despite doing that number also, every time I do an arch bar, okay, people know very well, my arch bar will be very tight and very good. Okay? That people know. But despite that, I will make sure I take every step into count. That means every time I do, I will make sure every time I will press it down before I tie. Because that's one of the reasons why my arch bar end of the day is tight, and it will remain tight for up to 3-4 weeks. Okay? Usually I tell you, if Fido or Endoc does, today they do 2 hours. Tomorrow morning you see already loose. Okay? 2 hours. How much of time I need to do arch bar? Less than half an hour arch. Okay? With fracture. Okay? Without fracture, don't ask lah. Okay? With fracture is less than half an hour. Okay? So you can times how many by factor lah, how long you will take to do it. So if you iron out every time you do it and leave it off to one side and tighten it last, safe. Like your friend here said, one tie here, in the middle it will mengembung, bulge. Okay? And you cannot rectify that, you know. You know how to rectify that? You will have to split the arch bar. Okay, we have to cut, which we do in OT when we're doing fracture reduction. Okay, when we're doing fracture reduction, some of the consultants would say, okay, let's split the arch bar. Okay, because if you don't split the arch bar, you cannot sometimes mobilize the fracture segment. So the area where there's a fracture, at that point, we will cut. Okay, so that we can immobilize the segment. Once you've got it immobilized again, the area that you've cut, right, you can re-tie back. Okay, some consultants who are even more neat, they will say, since we've already split, now we've already plated, remove the old arch bar, redo a new arch bar. Okay, yeah. So it depends who you're working with. Okay, because they want post-op, you're maintaining for 2-3 weeks. they want an intact arch bar which can survive for that period. Okay. Some consultants, after you cut in between, they'll ask you to put it back and put self-cure acrylic. Okay, so I've worked with so many people, right? But usually, let's not go there because that's OT work. But I'm just telling you, usually you need to cut if you want to rectify that bulge, which already tells you your arch bar is lousy. You know why? Because the moment you cut, you don't have that arch holding it down in one piece. It's now in two segments. Okay, it's now in two segments. You want the whole arch bar, okay, to hold it in one piece. Okay, because once you cut, it's already compromised. Got it? Okay. This is Eric arch bar, E-R-I-C-H, Eric arch bar. Okay. Invariably in Malaysia you get this. If you're in Western countries, you may have Jalenco. Okay, like Germany and all that, you may have Jalenco and all that. Here, I've hardly seen anyone using anything apart from Eric arch bar. Okay, so you don't need to be worried. You will most likely find this as long as you're in Malaysia. Okay, so are you clear so far? Anything that you'd like to ask? Okay, so I'm just giving this general thing first. As you all break down into groups, you can clarify further with me. Okay, on the nitty-gritty stuff. So now we've got the wires in. What you need to do is, you have your wire twister, one end, clip it sufficiently, because some of you clip just a little bit there. As you pull, it will slip. Okay, so what I will always do is, I will clip it sufficient length so that I can really work well, okay, and have full manipulation of the wire. Okay, instead of just clipping just this bit, clip the entire length of the beak. Okay, got it? Clip the entire length of the beak for the best stability. Alright. Another thing that a lot of people do and get killed is because they will clip the wire, but they won't clip parallel to it. They will clip like this. Typical. So what happens? What happens would be NSI. You know what's NSI? This is how they clip. Okay, this even some senior officers also do it. Okay, so that's why it's important to start off in the right habit. Because if you start off in the right habit, until you die also you follow that. Okay, because to rectify in between is very difficult. Okay, bad habit die hard, very difficult. What happens if you having it like this? Okay, needle stick injury. Okay, you'll be thinking what needle stick is talking about. Any sharp injuries during procedure, it falls under needle stick already. Okay, and how often people get injured during arch bar? Almost every attempt when they are junior. Okay, so very typical when we let FIDOs or NDOC to do arch bar. At the background you'll be like, shit, I'm going to have to do an incident report for this. Okay, because the patient, okay, is a patient who's a trauma patient who you don't know the background very much. You know, a lot of times they'll come in drunk, they'll have tattoo all over. Okay, so drunk, tattoo all over. Some of them are actually under influence, not alcohol, under drug influence. Okay, there's so many other signs. If you know the peripheral signs very quickly, you can one look I can tell this person is dangerous already. I'll tell my staff and DSA, wear double. Okay, yeah. If you're senior enough, so some people then pull me aside and ask, Doctor, how do you know this one? I'll know. And later you just memang either the HIV positive or Hep positive. Sure. Okay, how I know, don't ask me, because it's not your level. Okay. So don't have it sticking out like that. Okay, always clip the entire length there. So even when you're manipulating, there's no sharp ends. Okay, you must remember when you're doing, there's so many wires sticking everywhere. You know, okay, inside the mouth. Can you imagine there's a buccal mucosa here with your cheek? You know, it'll be very difficult to actually work. You're like actually working endoscopically, like in a tunnel. Okay, very limited vision, limited light. Okay, so you will never be able to tell exactly, if you're not careful, when you're going to prick yourself with the wires. So what we tend to do is, most places we will have sufficient wire twisters. Once we have this thing separated, mesial, distal, up and down, my technique will usually be to avoid that. I'll put all of them together and clip. Okay, I'll clip and leave it hanging one side. Okay, I'll clip and hang it one side so that I know my wire twister is holding it in a bunch and it's not going to poke me unnecessarily. Okay, so I'll bunch it up like that, and the free ones here also I'll bunch it up with another one. So what I'll do is only the wire that I'm going to work with I'll release from that bunch. The other one I just put it back on. Only the one I'm going to work with I'll put a wire twister and work. Got it? The others I'll have one bunch here, one bunch here. Got it? Okay? Safe. Alright, that's how we do it usually. Of course, as I said, different places that you're going to be posted to and work at will have different ways of doing it. Find to whichever way that you want to work. Okay, but this is how I usually do it, and you can prevent a lot of unnecessary, unwanted needle stick injuries or so on. Okay, because it's so easy to get yourself pricked with wires, especially when you're young. You're so enthusiastic to try to tie, and you forget about everything else, and you focus on the wire that you're trying to work with. Okay, so tie on both ends like that. Okay, as I said, parallel to the wire so that there's nothing sticking out here. You see, I can play with my finger around here, no worries, because nothing is there. Got it? Okay, and then the tying part. So I need help, someone? Can someone hold it for me? Hold the module. I need more than one person probably, because I need one person to hold the arch bar for me. Can I get out? Or if maybe it's too many people, what we can do is I'll show you all in smaller groups. It's difficult for you to see now. Okay, never mind. Up to this part, any questions? Okay, so up to here you're clear. Then just make sure you get your wires cut sufficiently. You should have at least about how many per arch? 6 to 8. Okay, 6 to 8 per arch. You have to have it for upper and lower. Okay, and then you have the arch bar cut according to the length of each of the arch. And then you be in your places. I'll take one of the group and I will show you how I tie. Okay, alright, because too many people you can't see. Okay, alright, thank you.